I'm Professor Hardeep Singh, Professor of Medicine, Government Medical College, Srinagar. Today I'll be discussing the recent advances in hypertension and what is happening around the world, what are the guidelines and what are the recommendations for India, what are the Indian statistics. To begin with, I start in India, prevalence of hypertension has also gone up over 30 years, and it has gone up to 38% in men and 32% in women. And it has gone, according to WHO records, it has gone in men from 29% to 38%. And in women, it has gone up from 28% to 32%, respectively. And despite the nearly half of the people of this hypertension, 50% of them were men, and 41% of women were hypertensive, and they were unaware of their being hypertensive, men as well as women. And over 62% of men and 53% of women living with hypertension didn't know that they were hypertensive and they didn't get treatment. So medication was used to control blood pressure in less than 1 in 5 men and less than 1 in 4 women, according to WHO records, which has come in Lancet in 2021. And as per WHO, of the 63% of total deaths in India are due to non-communicable diseases. Of these 63%, around 27% were attributed to cardiovascular deaths, and which nearly affects 45% of people in 40 to 69 years of age group. And this raised blood pressure, moreover, it remains poorly controlled due to low awareness about hypertension and due to lack of appropriate care through primary care and because of poor follow-up. International Society of Hypertension has released the ISH 2020 Global Hypertension Practice Guidelines, and the inclusion of optimal and essential hypertension paradigms attempts to address the issue that is in response in resource poor settings. And optimal they have taken as evidence-based standard of care, and essential standards they were taken at minimum standards of care. The American Heart Association and American College of Cardiology has released a scientific statement in 2021 offering new guidelines for management of stage 1 hypertension among low-risk cardiovascular patients. Among low-risk adults with no atherosclerotic cardiovascular disease or 10 years cardiovascular risk of less than 10%, with stage 1 hypertension blood pressure of 130 to 139 systolic and 80 to 89 diastolic, management starts with non-pharmacological treatment. If blood pressure remains uncontrolled at 3 to 6 months, consider starting pharmacological therapy, and it has come in Hypertension Journal 2021. As far as I discuss the role of ARDS, is a potentially fatal condition which involves lung damage, and experts associated severe COVID-19 disease recently. And recently, a study has come up in Journal of American College of Cardiology, which reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS, and those people who have additionally hypertension and who get COVID, their metoprolol has helped in these patients. This study has recently shown. Now, lowering of systolic blood pressure targets down to 110 to less than 130 millimeters range substantially reduced cardiovascular risk events in step randomized trial, which affirms the sprint findings, and in which they had seen the Chinese population among 8,500 patients aged between 60 to 80. In China, the intensive target just trimmed the 26% of the composite cardiovascular risk and new range thresholds of 130 to 150. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommend the diagnosis of hypertension should not be dependent on office blood pressure measurements, but also on out-of-office measurements such as ABPM or home blood pressure monitoring, and 24-hour and nighttime blood pressure measurements were associated with greater risks of mortality and composite cardiovascular outcome. Thus, they may be considered the most appropriate measurements of cardiovascular risks. For every 20 to 10 millimeters of mercury increment in blood pressure measurement at night, the risk of mortality increased by 23% and risk of cardiovascular events increased by 36%. So most patients with hypertension require lifelong medical therapy to achieve optimal blood pressure control. The 2018 European guidelines recommend 5 classes of hypertensive drugs, considering high non-adherence of treatment, the importance of combination treatment, in particularly highlighted to improve adherence to therapy and blood pressure control. Therefore, 2018 European guidelines recommend, especially in the context of lower blood pressure targets, to start antihypertensive therapy with the initial dual fixed dose combination of ACE inhibitor or ARB plus calcium channel blocker or a diuretic. Since early July 2018, the product containing valsartan have been recalled from worldwide, the reason being detection of carcinogenic and nitrodimethylethylamine, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. So the HYGEA group represents the largest study that they have seen the nighttime antihypertensive treatment effect. In this trial, the chronotherapy was associated with significant reduction in endpoints, including deaths. The HYGEA chronotherapy trial tested with nighttime therapy in comparison to usual upon awakening hypertensive therapy. It exerts a favorable cardiovascular risk reduction. So largest study included around 19,084 hypertensive patients, and they followed these patients for 6.3 years. And above these 1,752 participants expressed the primary CV outcome, and ambulatory blood pressure measurement was performed for 48 hours and to see the effect on blood pressure and during sleep. And risk reduction for cardiovascular risk was significantly improved for those patients who took up nighttime antihypertensive drugs as compared to early morning antihypertensive drugs. The nighttime outcome improved on these patients. This was the nutshell. Today we discussed about recent happenings and recent hypertension, recent guidelines, and recently what we have seen in COVID era, the effect of hypertension, diabetes, and the effect of which antihypertensive, the metoprolol they have recommended, reduced ARDS and inflammation in DBS. With this, I end my brief topic. Thank you very much.